Hi, everybody. Welcome to this ESS NatSen City St George's Survey Methodology Seminar. I'm delighted to welcome Erin Hunter, who's Assistant Professor of Global Health at Clemson University in the US, who's going to talk about an amazing project which was done a couple of years ago now, um, cognitively testing questions for the WHO's Sexual Health and Questionnaire, or the COTIS study. So without further ado, I'm going to hand over to Erin. Thank you. If you have any questions for Erin, then please use the Q&A. And at the end of Erin's presentation, which will be about 40 minutes or so, we'll then go through those questions. Thanks very much, and over to you, Erin.
Thanks, Debbie. And I do want to acknowledge Debbie was involved in the COTSA study from the early protocol development and on our steering group. So, Debbie, I'm really happy if you want to contribute to this and during the Q&A as well at the end. So, like Debbie said, I'll be using the seminar to give you an overview of the cognitive testing that we carried out in 19 countries to test and revise a new WHO sexual health questionnaire. And I want to highlight that this was carried out during the height of the COVID-19 pandemic. So this was a pretty monstrous undertaking, and we learned a lot. So I'm going to start the seminar by giving you a flavor of where we ended up, and then I'll walk back and tell you how we got here. How did we end up with the SHAPE tool? So SHAPE, the Sexual Health Assessment of Practices and Experiences, this survey questionnaire is now publicly available. It's housed on the WHO's website. You can use the QR code to access it. What is SHAPE? It's a global common set of priority questions assessing sexual practices, experiences, and health-related outcomes that's optimal for cross-national comparison. And the intention is that this tool can be used as a standalone survey or incorporated into broader health and demographic surveys. And it's intended for the general population ages 15 and above. So I'll give you a flavor of what is in this survey questionnaire. There's 6 modules. The first on personal information and health. So there's questions about sex assigned at birth, gender identity, living situation, health status, etc. There's then a module on sexual health outcomes, so questions about reproductive history, testing and treatment of STIs, testing and HIV status. There's a module on sexual biography, so we have questions about sexual history and use of contraception. And then a module on sexual practices, where we have a series of items asking about the most recent time a respondent has participated in, very specific sexual practices. There's questions about sexual pleasure, etc. We then have a module on social perceptions and beliefs. So a series of items on personal beliefs regarding sex and sexual and reproductive health. And then the tool finishes out with a module on sociodemographics. So we're asking about education, marital status, religion, etc. So that's where we ended up. This tool is available and endorsed by the WHO, but I'm going to use the seminar to give you a little bit of the origin story. How did we end up with this SHAPE questionnaire? So I'll touch on some early phases of the tool development quickly, but then the focus of the seminar really will be about the cognitive testing of the draft questionnaire that we went through in order to revise the questionnaire before it was made publicly available and endorsed for use. So I'll give you an overview of the cognitive testing, the COTSA study methodology. And as I move through the different components of the methodology, we'll discuss some implementation challenges and decisions that we made along the way. And then I'll close with highlighting just some key overall findings from the cognitive testing study and some lessons learned that might be of interest to those of you who are undertaking this type of work. So with that, let's start with the origin story of the SHAPE questionnaire. So back in 2019, HRP, the Human Reproduction Program, and WHO's Department of Sexual and Reproductive Health and Research held a technical consultation, and this was funded by the Wellcome Trust. And what this entailed was supporting partners to compile and review nationally representative data on sexual practices and sexual health related outcomes from around the world. Then global experts experienced in sexual health research and data analysis convened to review these data and to reflect on what was needed in order to improve their quality, availability, and global comparability. Um, and what did they find? Um, Essentially, there's very few places globally that are collecting these data, population representative data about sexual practices. And those few places that are assessing the same constructs or similar constructs in very different ways. And so it was very difficult to compare these data across nations. And so this consultation essentially identified a need for a global standard questionnaire for assessing sexual health related practices and experiences in a consistent manner that would enable cross-national comparison. And at that time, these experts drafted a list of priority content domains of what should be covered in such a standardized questionnaire. So that was back in June of 2019. From there, the WHO launched an open call to researchers, those who are currently conducting research in this space. They were to submit their tools, what items currently exist, what's being used now. Um, and that resulted in 175 unique submissions, which then led into a hackathon in Nairobi, Kenya in January of 2020, where experts sat around tables and kind of sifted through those submissions, looked at what items, what measures already exist, and then drafted this draft questionnaire covering those priority content domains. Where there were not existing measures or survey questions for certain content domains that had been prioritized, new items were drafted during this hackathon as well. So this draft questionnaire was really a compilation of existing questions from surveys across the world and some brand new items that were drafted specifically for the SHAPE tool. From there, the WHO conducted a technical review, both internally and externally, of this draft questionnaire. They used a modified Delphi exercise to get feedback from those who had participated in the hackathon and the original open call. And then that leads us now to the cognitive testing study, which we refer to as the COTSA study. We had a draft questionnaire in hand, but before the WHO wanted to make that available and endorse it, they recognized the need to do some rigorous cognitive testing in very diverse settings to enable an opportunity to identify a potential measurement error and to enable a good period of refinement before finalizing and publishing the SHAPE tool. So the purpose then of the COTSA study, which is where I kind of joined and headed up this portion of the process, was to cognitively test that draft questionnaire in a variety of demographic cross sections of the general population in diverse geographic and cultural environments. And this was to determine respondents' willingness and ability to answer those draft questions and determine whether questions were interpreted by respondents as intended across these very diverse settings. And then obviously with the ultimate goal of using those findings to revise that questionnaire. I realize this is a survey methods seminar series, and so I'm assuming that most folks on the call today are familiar with cognitive testing as a pre-testing method for survey questionnaires. I think most of us understand that bad survey items can leave participants really frustrated, and we know that they generate bad data. So how do we identify and avoid using bad survey items? we conduct cognitive interviewing. If you're a little less familiar with this method, in broad strokes, it's an approach to evaluating sources of response error in a survey questionnaire. It's a qualitative method, and it's designed to investigate whether survey questions fulfill their intended purpose. So we think about survey respondents as they hear a survey item or they read it. They interpret what they think they're being asked. They recall information that is necessary in order for them to answer that question. And then they map their answer on to kind of one of those response options that they've been provided. What cognitive interviewing enables us to do is sort of explore that process as the respondent moves through the process as they answer a survey question. And we particularly emphasize opportunities for breakdowns or problems in that process that may lead to response error, measurement error. So we conducted this cognitive testing in 19 countries, including low, middle, and high income countries across all WHO regions. This was a mammoth undertaking. So how was this organized? We had PIs and research teams in those 19 country sites. We had the global coordination team, which I headed up out of the University of Sydney prior to me shifting to Clemson in the US last year. We had WHO HRP as well as a study steering group, which was just absolutely instrumental in providing really good advice along the way. And you can see Debbie was a key member of that group. This is an image of the overall COTSA study methodology. I'm going to be walking through this, breaking it down, but I throw this here just so you can see the iterative nature of how we approach the cognitive testing, beginning with adapting the core protocol for those 19 country contexts, translating the draft questionnaire, obtaining ethical approval. And then we had 3 waves of data collection. So those 19 countries were broken into 3 groups. We would do a wave of data collection, analysis, hold a joint analysis meeting with those country teams that had participated in that wave, translate those findings into revisions to the tool, and then use that revised version of the questionnaire for the subsequent wave of data collection. So we did this 3 times. And notably in that the final wave 3 of data collection, we had the final group of countries that were implementing their cognitive interviewing for the first time. But we also had countries that had implemented cognitive interviews in the earlier waves join in wave 3 as well and do some additional cognitive interviews using the latest version of the tool by that point, which was really helpful in exploring, okay, some of the changes that we've already made throughout this process, how are those now performing in those sites? And then you can see on the right side, we finalized the shape tool. So what does that look like within each site? So, a given country team adapted the study protocol and translated the draft questionnaire. They underwent training both internally and at the global level. They implemented their first round of cognitive interviewing with an aim of conducting about 24 to 32 interviews in their site. They contributed to revisions of the instrument, participated in a second round of interviewing during that wave 3, and then contributed to the final revisions. So the intended study sample was the general population, ages 15 and above, and this was to include participants across sex and age groups. And participants were purposefully sampled, and then a minimum of 10 participants in rural communities in each site was kind of our intention. So kind of moving back then to this overall methodology, I'm going to walk us through this step by step. And as we move through, highlight some implementation challenges when undertaking something of this scale during a global pandemic. So beginning with translation of the draft questionnaire across all of these country sites, and adapting the core study protocol um, to the realities of the local context and obtaining ethical approval, both locally and at WHO headquarters. Let's start with a discussion of translation. Um, the global coordination team made a set of minimum standards available for country teams to follow as they developed their plan for the translation of the tool. And we really emphasize, this was happening at the time that country teams were in the middle of adapting the protocol, trying to get ethical approval. There's a lot to happen. We want to get that submitted as quickly as possible. But we really highlighted the importance of not just doing a quick and dirty translation just to get something submitted to the ERC, but that this was really the first step in doing this process well. Um, so there were some small variations across study sites, but in general, translation procedures included a forward translation from English to local language, a back translation conducted by a separate individual, and a panel of experts to adjudicate and to identify discrepancies. And they kind of iterated until they were happy with the final product. So that's translation, but when it comes to adapting the core study protocol for the local context, and like I said, receiving ethical approval both locally and WHO headquarters ERC, this it was a very complex process and very lengthy, and so this had knock-on effects. We were actually delayed in launching data collection because of the complexities in adapting a core protocol across such diverse settings. I'll give you just a flavor of what some of the ethical considerations that we were working with were, and maybe touch on some lessons learned here. Um, the core protocol for the cognitive testing study called for waivers of parental consent for minor participants. But during the adaptation phase, it was made apparent that this was deemed unethical in some settings, while deemed very ethical in others. And so there were discussions and decisions made to make some local adaptations around requiring or waiving parental consent, and sometimes that impacted the minimum age of participants in the study for certain settings. Um, there was also a diversity in kind of the legality of certain activities that are discussed in the survey. So we had some settings where sex outside of marriage was illegal, and other settings where certain sexual practices were illegal. So a lot of work went into determining how we should adapt the protocol to ensure that we weren't putting participants at risk. Um, so there were also some differences, like I said earlier, this is happening during the pandemic, so there's some differences in modalities and consent procedures where we have some settings conducting in-person interviews where it was safe to do so and using written consent, where in other sites we were doing cognitive interviews over Zoom because of lockdowns due to COVID-19. And so differences there in digital consent, etc. We also learned that a lot of counsel was required around preparing for mandatory reporting requirement procedures. A lot of teams were not fully aware of mandatory reporting requirements in their setting. And so there was a lot of kind of advice being shared across teams, the global coordination team able to help facilitate kind of communication across teams around how to approach these procedures. So we learned one size does not fit all, and to kind of go into this process thinking absolute standardization across every single setting is a must. That would really create more problems and actually contribute to, in some cases, some less than ideal or less than ethical activities, and or have impacts on quality of data. All right, so now moving, once we have ethical approval, moving into training and data collection. Um, the way we approached training across all of these sites was to house a study website where we had the manual procedures for the study, a study training guide, pre-recorded training videos, a resource library, and contact information. And each team was to follow the study training guide in preparation for 3 live sessions where they would join with other teams participating in the study. So, leading up to each live session, individual country teams would read sections from the manual of procedures, watch pre recorded training videos, and then complete internal training activities in preparation for sharing together at the global level during these live sessions. Live sessions really focused on participatory activities, practice, getting feedback with different skills, and sharing across teams kind of, okay, what this is going to look like in our setting. And then they could kind of cross-pollinate and really firm up their approach for implementing the study. Um, there were also VCAT workshops made available, values clarification and attitude transformation workshops, in recognition that the survey questionnaire is asking about very sensitive um, uh, information. And so these workshops were offered by APHRC in Kenya. So we've trained, we're ready for data collection in a given wave. What did that look like exactly? Um, Interviewers used a semi-structured interview guide that had the survey questions that were being tested along with suggested scripted probes, although they were free and encouraged to use spontaneous probing in addition to that. They also had access to a detailed item-by-item description document which outlined the measurement aims of each of those items to help them kind of feel empowered during their cognitive testing. The interviews were audio recorded. Interviewers took field notes, expanded those, and created local language transcriptions. After the first 2 interviews were conducted in a given site, the team would then meet with the global coordination team for an initial debriefing meeting. And this was critical. This really enabled us to identify issues very, very early on and kind of redirect. Maybe that involved a little bit more training on cognitive interview methods, or we could identify some initial translation errors at that point. We're able to redirect course and not move through the entire period of data collection before those were addressed. After that, teams had internal debriefing meetings as they iteratively collected data within their site. Now, when it comes to data analysis, conceptually, we were thinking about this kind of occurring in 3 levels. This is pulling from Miller and colleagues' approach to analysis of cognitive interview data. That first level of analysis really happening during the interview itself, when the interviewer is analyst, and kind of being on the lookout for kind of clues or signals that the way a participant is interpreting a question may be out of alignment with the intended purpose. And so they're able to kind of explore in the moment why that might be. They're on the lookout for hesitations or other issues with response options, etc. The second level of analysis is when we're looking at identifying patterns of interpretation and question failures across all of the participants for a particular item. And then the third level of analysis is when we're going a bit of a step further and seeing if there's differences in these patterns across particular subgroups. And this was occurring both within sites and across the sites at the global level. So what did this look like in practice? Kind of what were the analysis procedures exactly? Um, Study teams would audio record, transcribe the interviews in local language, expand their field notes, but then summarize what was occurring in a given interview into English language summaries in a data analysis framework, which I'll show you in a moment. And then they would prepare for a joint analysis meeting by creating a bulleted list of key findings for each of the survey items that were tested. So they would offer a tally of responses, a summary of ease of difficulty responding to that item, patterns of interpretation that they identified, any specific issues or concerns, and then recommendations for revision of that particular item. This is what the data analysis framework looked like. So those English language summaries were appearing in this data analysis framework. There was a tab in the spreadsheet for each item being tested, and then you can see space for the response that the participant provided to the survey question, and then summary of what took place and what conversations were had regarding kind of in response to scripted probes, as well as space for interviewers to fill in additional information and observations that help us understand how these questions were being interpreted and responded to. So then when it came to the cross-site syntheses, the global coordination team used the bulleted summary documents and the data analysis frameworks from each of the sites in a given wave. Looked through that together to synthesize findings across sites. So we identified patterns in interpretation and question failures for each of those items across every site in a given wave. During this, we're reaching out to country teams to help clarify when we have certain questions, and then we shortlist priority issues to discuss during a joint analysis meeting. We held a joint analysis meeting via Zoom after each wave of data collection. And then following the jam, we would incorporate recommended changes and revise the questionnaire and have it ready for use in the subsequent wave of data collection. So this is how we documented changes between versions of the tool. We would just keep, a running list of what the current version of an item looked like, a summary of the major issues that we identified, proposed changes, and then we're documenting kind of the transition, the new version of a particular item. So we're keeping track of this as we move through each iteration. And then we do another wave, and then we do it again. So after all of that, what did we end up with? We ended up conducting 645 cognitive interviews across these sites. Ages of participants ranged from 15 to 86 years old, with a mean age of about 34 and a half years. So over 2 years, 19 countries, 3 waves of data collection, 3 joint analysis meetings, and a lot of cognitive interviews. What did we learn? We learned that there are many ways of interpreting the very same question. Unbelievable number of ways of interpreting the very same question across sites and participants. And interestingly, we found question failures or issues with items that had been taken from existing surveys that are being used across the globe. We found issues with those items at roughly the same rate that we found issues with items that had been newly developed for the SHAPE tool. So we weren't just finding issues with these new items that had never been tested, but we were also seeing issues with questions that we take for granted and that are used routinely. In general, we identified issues that affected the willingness and the ability of participants to respond fully. So these were issues around acceptability and some knowledge barrier issues. And then we identified issues that prevented participants from interpreting the questions as intended. So this was predominantly poor wording in the source questionnaire. And then there were some cultural portability issues and very rarely some translation issues. So I'll use the next little bit of the seminar to give you a flavor of what some of these types of problems looked like. So regarding acceptability, overall, participants were willing to respond to the questionnaire items. They would note sometimes that this was really sensitive, but they were still willing to respond to them. We had participants remarking on their appreciation for being involved, for having the opportunity to talk about some of these issues that they've never been able to talk about before with others. But there were some exceptions. We had a few participants who felt certain items were either too exclusionary or irrelevant to them personally or out of alignment with their values. So where we saw this, there were some participants who felt the module exploring social perceptions and beliefs. They found that module to be to it was quite gender binary. And so we had comments about it being a bit too exclusionary, that it didn't make space for non-binary individuals. And then we saw issues occasionally where when participants were asked about, the most recent time they participated in very specific sexual practices, if they deemed that particular practice irrelevant to them or even kind of out of alignment with their values, we would see non-response. They would just not respond to that item instead of selecting the never response option. And then we also had participants who had experienced non-consensual sex, feel unsure whether they were supposed to include those experiences when responding to certain items. So like questions about age at first sex, number of sexual partners, satisfaction with sex life, etc. And so the original version of the tool was less acceptable for participants with these experiences. Knowledge barriers. This wasn't a tremendous issue, but we did see this pop up in an item about intersex variations. People not being able to respond because they didn't know what they were being asked, or a lot of times kind of misclassification occurring because they were interpreting the question to be about gender expression or some other constructs. We also ran into this issue in questions about sexually transmitted infections. I don't think I'll use too much time now to go into the details of that, but you can see an example in a paper that just came out on the study of how we approached questions to overcome some of the knowledge barriers there. The main source of issue came from imprecise wording in the source questionnaire. Some of these issues were very easily resolved by creating a few points of clarification. Other times it required a heavier lift. Here's an example of an item that wasn't really prioritized for cognitive testing, but we learned very early on that it was very problematic. We had an original item that said, "Are you at present single, married, separated, but still legally married, divorced, or widowed?" Participants nearly across the board were interpreting this question to be about relationship status more generally and not about registered kind of civil or marital status. And so unmarried participants would not endorse that single response option. We had a lot of non-response and frustrated participants because they didn't see themselves reflected in this survey item. And so this was later changed to very directly state what the construct is that is being assessed. So what is your marital status? And the single response option was changed to never married. We also had issues where maybe one question was tapping multiple issues, but only allowing one response. So an example of this is an item that asks currently in your everyday life, i.e. at work, on the street, at home, how safe do you feel from sexual assault? Participants expressed how their feelings of safety at home differed quite substantially from their feelings in other contexts. And so there was a lot of noise being created in the data from this question. We had some people who were sort of averaging their experiences and coming up with their response. We had some who just chose to focus on inside the home or outside the home. Long story short, we split that question into two. So asking about how they felt at home, and then another question on how they felt outside the home. And then we changed the response options that were causing a fair bit of confusion as well. We also had some issues with Likert response options in some of the items in that module on perception, social perceptions and beliefs. An example, is it okay for women to have an abortion if she does not want to have a child? the original response options were strongly agree, agree, disagree, strongly disagree, prefer not to answer. This was all over the shop. So we had participants not responding because we just heard time and time again, they wanted to express more nuanced views because they said it depends. Like I would agree in certain instances, but not in others. And so we had, some people just choosing not to respond because that nuance wouldn't be appropriately reflected. Or we had some people kind of choosing to focus on one aspect or trying to average again. And this was just, again, creating a lot of noise. We and then we also had, when you would see the qualitative data, kind of understanding what a participant felt and how they came to their response, we would have participants kind of describing very similar beliefs, but then the actual response options that they chose were just dramatically different. So we knew that keeping a question like this and then using those quantitative data to make conclusions would just be really ill-advised. And so we ended up completely overhauling the structure of this item and some other items in that module to say which of these statements is closest to your personal view. And they could select, it's okay for someone to have an abortion for any reason if they want to. It's okay, it's only okay for someone to have an abortion under certain circumstances, or it's always wrong for someone to have an abortion regardless of circumstances, or prefer not to say. Now, regarding cultural portability, some items had to be dropped from the ultimate tool because of really diverse conceptualizations of the constructs intended for measurement. And so this made standardization infeasible. An example of this was the item, the most recent time you had sex, what did you consider the ethnicity of the person you had sex with to be? This question was problematic in nearly every site. Conceptualizations of ethnicity varied tremendously. So we had in some sites, this was, thought of as tribal affiliation or color of skin or religion, etc. Um, we saw that in certain settings that are quite ethnically homogenous, that participants of the predominant ethnic group were just completely confused as to what was being asked. They would respond with their nationality. We had a lot of participants in some sites questioning the item's relevance or saying that the item was offensive to them and sometimes even considering it to be racist. And then in countries where ethnic conflict is really common, this item was extraordinarily sensitive. And then lastly, translation errors. These were very rare, and we really attribute this to the rigorous translation plans that were developed at the very outset. So that was really encouraging. A blatant translation error was identified pretty easily when we saw that a particular item was failing in only one site and nowhere else. So it was a quick clue to us. Let's look at the translation, what was happening here. The translator had just failed to complete the rest of the item. They just didn't finish the rest of the question. So participants were understandably confused. And we did occasionally see some issues arise where an English word in the original version, like okay, which could be translated in multiple ways, that caused a little bit of confusion for sites as they were trying to adapt the tool. So we ended up adding translation notes in the final tool to maintain the intended meaning of all right or personally acceptable. All right, so translating those findings into questionnaire revisions, like I've alluded to, we did a lot of revising item wording, restructuring, changing response options, changing the order of things. And this was all done to kind of help improve that match between participant interpretation and the measurement intent of items. Like I said, we removed items that tested poorly across sites, even despite multiple revision attempts. If we just couldn't get to a place where it was uh, you know, generating good quality data, then we had to take it out. We added a lot more informative preambles and we improved skip logic to be more sensitive to the participant experience and particularly for those who had experienced non-consensual sex. We also use the findings to develop some detailed implementation guidance that appears in this published toolkit. And overall, we try to improve inclusivity while also endeavoring to remain interpretable across the general population. So there was some tension there throughout the process, but that was our aim at the end of things. So as I'm rounding out our time here, some key takeaways from managing such a complex endeavor. Um, Cognitive interviewing as a pre-testing method for survey questionnaires is still an underutilized method in a lot of global health survey research. So I think a lot of folks on the call may be coming from other settings. This may be extremely routine for you. This is nothing new, but it is in a lot of settings globally. And it was cool to see upon kind of gaining experience with this method, which was very new for most all of the team members implementing this study across sites. Upon gaining experience, research teams really quickly recognized other typical approaches to translation and pre-testing of survey questionnaires is really insufficient. So there was a lot of interest in, taking this forward in their work in other areas, which is exciting to see. Another key takeaway, though, is not to underestimate the training needs, particularly for teams where cognitive interviewing is a new method. This is not a skill that comes necessarily very quickly overnight. And so a lot of time and effort needs to be put into really ensuring that research teams are skilled in this method before carrying out a cognitive testing study. A big learning for us was the need to make sure that study team members are really clear on the measurement aims of items before the cognitive testing is launched. We sort of inherited the draft survey questionnaire. I was not involved in the earlier phases back during the hackathon and other events. So we had this draft questionnaire at the start of the COTSIS study. And we didn't always necessarily have the measurement aims for each of those items explicitly laid out. So we had to do a bit of detective work on our own before launching the study to try to track down exactly what these items were intending to tap. And sometimes there remained some ambiguity. And so, these aims should really be made explicit from the very outset, and study team members across the board should be aware of them. This really empowers them during a cognitive interview to be able to recognize, oh, I think we might be having some indication here that an interpretation is not necessarily aligned with the intent. And then lastly, the importance of being flexible. Like I said, when working with so many teams across such diverse settings, kind of going into an endeavor like this, thinking absolutely everything needs to be standardized, everybody has to do the same thing in the same way across all sites. That was really going to set folks up for failure. We needed to be we needed to acknowledge the local realities on the ground and be flexible with some adaptations in how the study was implemented across sites in order to ensure that we had quality data and that activities were done in the most ethical way with the best protection of study participants. And with that, it's been a whirlwind, but I wanted to acknowledge the institutions involved in the testing. And then here you can access the Finalize Shape tool. And we had a recent publication in the past couple of weeks with the Bulletin of the WHO overviewing the COTSIS study. Additional analyses are coming down the line that will focus on particular items in depth and kind of individual country context, etc. So, all right, over to you, Debbie.
Thanks very much, Erin. That was a really interesting presentation on what was a massive undertaking to do that testing. Can I remind people to ask their questions in the Q&A, which we have available at the bottom. You should see it at the bottom of your screens if you're joining on a laptop. So I have a question from Rory Fitzgerald. who says, thanks for a great presentation. You mentioned testing in 19 countries. Could you say a bit about how you selected them? And as a follow-up, do you think so many countries were needed, or could you have managed with fewer?
Yeah. So this is actually getting to, again, earlier phases of the development that I was actually not involved in. So the WHO and HRP went through the process of partner selection. They had an open call. So any research teams globally were able to respond to that open call with an application. And HRP, WHO had some criteria that they were looking for in partners regarding experience in sexual health research, qualitative research methods, um, etc. So unfortunately, I can't speak to all the nitty-gritty details of what that process looked like, but there are some descriptions of that process available through WHO publications, and it's touched on in the earlier portions of the SHAPE publication. I Again, I was involved from the beginning. So Debbie, you might actually be able to speak to some of this because I think you actually jumped on board before I did and were privy to some of these earlier conversations. I think honestly, we could have benefited from a smaller piloting period with kind of a bit more of a delay before we really fully launched because I think we started with the first wave was very small. We only launched it with initial like 4 or 5 countries because, if something went awry, we didn't want to have so many people involved from the outset. But then there was a lot to work out then, right? But then we had all these other country teams already queued up, like waiting to go. And, as things get delayed because we realized, oh, we you know, could have fixed a lot of things really quickly with just a very small piloting period. That had knock-on effects in terms of like delaying other country teams that had been like geared up, had their folks ready to go. So, yeah, I think there is something to be said about kind of starting small with a little bit of a pilot. You can learn a lot really, really quickly before you then extend to a massive scale.
Mhm. Yeah, my recollection was from working with colleagues at WHO was that there were some concerns about the acceptability of
Hmm.
some of the questions, and they were particularly keen to make sure that all parts of the world were included in the testing, to make sure that, part of this was about being able to demonstrate the veracity of this new tool, um, to encourage people to use it. So I think there was a sense of feeling like the testing needed to be cover a
Yeah.
lot of different parts of the world, to give it credibility for people
Hmm.
to want to include it, um, because I think the idea is that these questions getting could be incorporated into existing either national surveys of health and
Hmm.
sexual um, well-being, or perhaps be part of a standalone survey. So they wanted people to have, confidence
Hmm.
that the items had been well tested.
Yeah.
Thank you. Um, so Michelle asks, were there adequate processes in place in all the sites for ethical approval? How did
The,
you handle this?
yeah. Repeat the beginning part of that question again.
Were there adequate processes in place in all sites for ethical approval?
Yeah. So, like I said, there was a core protocol for the study, and then it was up to each individual site then to take that core protocol and localize it, right? So they are creating a local protocol that would go through ethical approval at their institution's ERC. And in some settings, they are also required to go to a national level ERC. And that local protocol was also submitted back to WHO headquarters ERC. So WHO ERC had approved the core protocol, but then also looked at all of the individual local adaptations. So we had local approvals, sometimes national approvals, and WHO ERC approvals. Um, because it is a study that was touching on sensitive topics and in some cases practices that are illegal in certain settings, there was a lot of time spent on teams trying to do this well, reaching out to the global coordination team to kind of problem shoot and throw around different ideas, basically trying to understand how much leeway do we have in terms of kind of do we have to stick like to the letter of that core protocol, or where can we make adaptations that we feel are necessary to ensure that this is done ethically in our setting. And then we facilitated conversations between teams. We're saying, okay, this team has run up against this issue. These are some of their ideas on how they're going to put protections in place, et cetera. Is that kind of getting to the question that was asked? This process was very lengthy. There was a lot of counsel provided and a lot of discussion within and across teams. And like I said, that did have knock-on effects in terms of delaying data collection, but it became apparent very quickly that this should not be done, um, quick and dirty just to get a submission through, but that this is something that was really worth the time and effort to do right from the beginning.
Great, thank you, Erin. Michelle, do let us know if you've got a follow-up question um, to your earlier one. So Patrick Sturgis asks, if I understood the procedure correctly, was there a reason you did not first cognitively test the English-based questionnaire before translating?
Yeah, so there's some difference in different approaches and opinions. We weren't we were trying to approach this without kind of prioritizing or overly emphasizing the English version. So, we were, yeah, long story short, we did ensure that we had a country site that was testing the English version in that first wave. So we out the gate had some clues to issues with the original English version early on, but that was not done completely separate to other countries joining in from the very beginning and contributing, their findings on how items were interpreted.
Great, thank you. And Lisa Menning asks, congrats on this enormous undertaking. How are you now supporting and tracking use of the final published tools?
Um, so of the final tool of the shape questionnaire itself. On the website that the WHO has, which houses the tool, they are tracking information when folks download the tool, and there's a red cap version of the questionnaire available. They made efforts to collect information. Folks that are downloading and using those tools can share their name, contact information, and kind of who they're affiliated with, and if they want to explain their intentions for using the tool. It I don't believe it's been made mandatory. It's publicly accessible, but WHO HRP is making efforts to kind of track what people's intentions are and who is using it and where. And there's guidance provided in that toolkit around um, those who are using the tool, what we would like to see them report on, because we recognize, right, we did some pre-testing, we did cognitive testing, which yields a lot, but it's not the end all be all, right? There's still so much to learn about the tool and further improvements that could be made once it's actually fielded, and we have the quantitative data along with it. So uh, we've laid out suggested reporting requirements. So as we continue to improve the tool over time, we have enough information from those who use the tool in order to understand kind of how to compare findings and really understand what's going on.
Great, thank you, Erin. So there's a question, will there be any possibility that could include more than one binary gender in future?
Can you repeat the question?
So the question is, will there be any possibility that could include more than one binary gender in the future? So I think you showed an example. I think you talked about the example of asking about gender earlier on in your presentation.
Specifically, the item about current gender identity.
Hmm.
Um, so yes, there is opportunity for participants to report. Um, I'm trying to, did I share in our ultimate, what we settled on as the ultimate version of that item? I don't think I did. Um, but it allows for a diversity of gender identities. So that is built in inherently to how participants are able to respond to that item. Is that answering the question of the submitter?
Yes, if well, I don't know if they can let us know through the
Yeah.
Q&A.
I can
Um,
also mention, so I did highlight how participants shared that they felt the entire module around social perceptions and beliefs, that there was, a strong kind of gender binary in that module. We did make revisions to that in the final tool. We looked at items where um, they didn't need to be gender specific. And so items that could be revised in that section to be gender neutral were revised to be gender neutral. And then we maintained gender language in certain items that were very specifically intended to assess perceptions or beliefs around um, particular gender identities.
Great, thank you. Janiska asks, um, it was said that cognitive interviewing is an underrated method. What arguments would you suggest to encourage clients to include it in their project?
Yeah, goodness. Because, it takes a lot of time and you need more money and time to include it. But I think as very, very quickly, as soon as folks see what it can yield, and I think maybe demonstrating some examples of questions that seem quite straightforward and innocuous, maybe sharing some examples of different interpretations that participants can arrive at, hopefully could demonstrate its utility. I think there's some particularly related to global health survey research. There's a few articles in the literature by Scott and colleagues that have done a fantastic job of laying out issues that they have found in the use of tools, items that have been very widely used and just taken for granted that they're good measures. And then they've provided some evidence of the noise and the data created from just interpretations all across the board. So I think sharing some very specific examples of that can quite quickly make people realize, oh, there is a true utility to this. But again, it requires time and money, and I think that needs to be incorporated in plans from the outset.
Great, thanks, Erin. We have a couple more questions, but we're out of time. So I wonder whether it would be possible for you to answer those questions after we've closed the session, and then
Yeah,
we
definitely.
can share those in some way with the participants,
Yes, very
if
happy to.
that's okay. Well, thank you so much, Erin, for a really fascinating presentation. And I wish everyone a good seasonal break that's coming up, and we look forward to welcoming you to our future webinars in 2025. Thanks very much. Thanks so
Thanks so
much,
much,
Erin.
Debbie.
Thank
Take
you.
care.
Bye bye.